with this, so we can have a level of asthma control. Okay, so we use this whether your asthma is controlled or not. We'll ask all these questions and then do the lung function to see whether there is a asthma control or not. So this is important for escalating and de-escalating of the treatment. Then coming to the level of control, then you can go for control or partly control, and treatment action is control. You can so we can maintain and find the lowest controlling step. Okay, and then it's a partly controlled, consider stepping up to the then the control, and uncontrolled step up until control, and exacerbation is there, treat as a exacerbation. Okay, so this is the mainly thing that we are going to do. And then increase the treatment. Okay, so increase the treatment, and you can go for the step 1, step 2, step 3, and step 4 on the treatment guidelines. Okay, stepwise treatment of asthma. Shilpa, hi. Sorry, join got the race. And then coming to the personal asthma management, so this is the given by the Jinnah. Okay, so you should confirm and diagnosis if necessary, and symptom and control and modifiable thing is there, and risk factors like including lung function, comorbidities is there, whether you have to assess whether there is a inhaler techniques is right or not. Okay, so you have to first assess and adherence, and then the patient and parent preferences and goals. Okay, so that's mainly a important thing. So always ask if the patient of the asthma they are using the inhaler technique is right or not. Okay, so only prescribing is not a job, so you have to see whether the technique is right or not, because this is the mainly a thing where there is always a chance of having a um, exacerbation if the patient is not taking the inhaler and the right techniques. Then another is the adjust. We have to adjust the treatment of the modified risk factors and comorbidities. Then non-pharmacological strategies, asthma medications like adjust down or up between the tracks that you can do. Education and skills training is mainly important. And then reviews. Okay, so you have to review the symptom, exacerbation is there or not, whether there is a side effects or not, lung function, and then the satisfaction of the patient. So this is the ideally case circle that you are using: review, assess, adjust. Okay, so that's mainly a personalized asthma management. Then coming to this, so always in all the steps that you are using this review, assess, and adjustment. And now, so this is the steps that you are going to use is the step 1 and 2 and step 3, step 4, step 5. Okay, so that's mainly the thing that you are going to uh, use. Sorry. So in this, what you have to use as needed low dose ICS formoterol. Okay, so in step 1 and 2, you can use the as needed ICS formoterol. So now this has been changed. Okay, so this year, you can use now this ICS and formoterol. Okay, previously what is there? You can use the SOS bronchodilator only, but now you have to use the combination of SAVA and this lava and ICS combination. Okay, and take ICS whenever and SAVA taken. Okay, so but you have to use the SAVA means short acting salbutamol. You have to add on ICS. Okay, so ICS, you take ICS is the important. So now you have to use the ICS in every step of asthma medication. Okay, so medication. So that's mainly a chance that has happened. And in step 3, what you are going to do is you have to go is mainly use the low dose maintenance ICS and formoterol. Okay, step 3. And then step 4, that you are going to increase through the medium dose maintenance ICS and formoterol, and medium and high dose maintenance ICS or formoterol that you are going to use, or you can use an add-on LAMA or leukotriene inhibitors. Okay, so or switch to high dose ICS, so you can use that. Okay, so these are the things that you have been using to add on. And then add on llama, refer to phenotyping assessment. Okay, so you can use the anti-ig, or you can use the anti-il-5, that is a resoluzumab, or anti-il-4r. So these are the monoclonal antibodies that you can use if there is a phenotypic assessment is there. Okay, so if the more of these antibodies are there, then you can use the these monoclonal antibodies, or consider high dose ICS and femoral. So this is the mainly thing that you are going to use in the step of therapy. Okay, so this is not given in your Davidson. So this is a new guideline. Okay, so this might be come in the coming edition. Okay, so whenever you are going in your final examination, so the edition might be changing. They will incorporate this step. Okay, so this step, so you should have access to this. So you can get this from the GINA guideline. Okay, so GINA guideline. Then starting the treatment. So as I already told that the first assess and confirm the diagnosis, symptom control, comorbidities, inhaler technique and adherence you have to look for. Start here if control using ICS and fermenter as a reliever reduces the risk of exacerbation compared with using the SABA reliever. So that's why you have to use this as a reliever, ICS and fermenter. Symptoms less than 4 to 5 days a week. If the symptoms most days, or waking with asthma once a week or more. So as this been used as a already been controlled or uncontrolled, so it is uncontrolled. Okay, uncontrolled, then you step on that, and then if it is daily symptoms is still not controlled, then you can go with this step. Okay, so this is step, and in this step you can use the short course of oral corticosteroids may also be needed for a patient presenting with severely uncontrolled asthma on this. Okay, so that is also known as a brittle asthma. Brittle asthma on this group of the patient, and you can try with the all these anti-ig, resoluzumab, and all these monoclonal antibodies. So what percent of the adults have a severe asthma? So 25% has a high intensity treatment, can have 17% difficult to treat asthma will be there, and 3.7% will be have a severe asthma. Okay, so severe asthma can be there. So how to treat the patient with severe asthma? So this is the box which is given in your Davidson. Uh, so you have to measure the peak flow expiratory rate, convert PF to percent best or percent predicted. So if life threatening and acute severe asthma is 0 to 50%, so in this you go for ABG, arterial blood gas analysis. You give the nebulized salbutamol 5 milligram or torbutalin 2.5 milligram 6 to 12 times daily or as required. Then give the oxygen that can be given at the high flow, that is 60%, and prednisolone oral. You can give 40 milligram orally, or you can, if the patient is not able to take the oral, you can go for the injection hydrocortisone 20 milligram IV. Okay, and then you have to go for the intravenous SS, chest X-ray. You do plasma theophylline level is available, you can do that, and plasma potassium level. Okay, so and then admit the patient, administered repeated salbutamol 5 milligram plus ipratropium bromide. You can give by the nebulizer, by oxygen nebulizer. Consider continuous salbutamol nebulizer 5 to 10 milligram per hour till the bronchospasm is not there, and consider the intravenous magnesium sulfate. So magnesium sulfate here is acting as a bronchodilator, so you can use as a 1.2 to 2 gram over 20 minutes, or aminophylline. You can add on 5 milligram per kg loading dose over 20 minutes, followed by the 1 milligram per kg per hour infusion, and correct fluid and electrolysis, especially potassium. Okay, so this is mainly an important thing that you have to do in the life-threatening acute severe asthma. And if it is 75% to 51%, is a moderate. So then it's the arterial blood gas. You can give nebulization, then the oxygen high flow, prednisolone 40 milligram oral, wait 30 minutes, measure PF. If peak expert flow rate is less than 60% of the predicted, you follow this side. Okay, and if the peak expert flow rate is more than 60% of the predicted, you can go for the home treatment, like check with the senior. You can discharge the patient. Okay, and then prednisone 40 milligram daily for 5 days, start or double inhaled corticoids. Okay, and return immediately if worse of the symptoms, and appointment with the GP within 48 hours that you can use. And if it is 100 to 70 is a mild, did patient receive nebulized therapy before PF recorded? If it is no, Then usually inhale bronchodilator, wait for 60 minutes, and you can discharge the patient to home. Usual treatment, return immediately if the hours of the appointment with a GP within 48 hours. So this is how you are going to manage the asthma in the hospital emergency setting. So what is the indication of assisted ventilation in acute severe asthma? So it's mainly if the patient is comatose, if the patient is respiratory arrest, and if the patient has a deterioration of the atrial blood gas tension despite optimal therapy, if PaO2 is less than 60 mmHg, that is 8 kilopascal, okay, and falling, and partial pressure of carbon dioxide is increasing more than 45 mmHg and rising, and PS low and falling, then the if high and rising is there, then you can and there is exertion and delirium and the drowsy, patient is becoming drowsy, then that's the indication of you going for the assisted ventilation in the form of non-invasive ventilation, or you can use the mechanical ventilation, that's the mechanical ventilator. Okay, so that's the mainly indication of ventilation in the acute severe asthma. So lastly, so what is the key message? So asthma is a common disorder, so it can happen to anybody anywhere. So it is not caused by the supernatural forces. Asthma is not contagious. That's mainly a thing that we have to tell the patient. It produces the recurrent attacks of the cough with or without wheeze. So between the attacks, people with asthma lead to the normal lives as anyone else, and in most cases there is some history of allergy in the family. And then the asthma can be effectively controlled, although it cannot be cured. Okay, so effective asthma management programs include the education, objective measures of the lung function, environmental control is the most important one, and the pharmacological therapy. And there should be a stepwise approach to the pharmacological therapy is recommended, and the aim is to accomplish the goals of the therapy with the least possible medication. Okay, so first you titrate and increase the dose, and if the patient is being controlled, then you will step down. Okay, so first step up, and at what stage the patient is controlled, then try to step down, and which patient in which step the patient is controlled, you can leave that and still try to step it down. Okay, so this is how you can go with the asthmatic stepwise management. So with this I conclude the today's lecture. Okay, so the next lecture I will go with the chronic obstructive pulmonary disease. Okay, so one of the important and most common disease which you are encountered in your clinical practice is the COPD and asthma. Okay, so the asthma pandemic, COPD is more common. Okay, so more common with the age that you are going to encounter in everyday medical emergencies. Okay, so that's the thing. So if there are any questions, you can ask me, otherwise I can conclude. Case her. Any question? CR कि सबजना छुट्टीमा गइसक्यो अन गरेर. सचिन के छ? ठिक छ?
सर वेल हामी किन त्यो प्यासिभ स्मोकरमा मात्र फोकस गरिरहेछौँ तर स्मोकिङले चाहिँ कज गर्दैन जो एक्टिभ स्मोकर छ
त्यसमा हैन, त्यसमा तिम्रो प्यासिभ स्मोकिङ, त्यो स्मोकिङले कज गरिहाल्छ नि. प्यासिभ स्मोकिङले पनि गर्छ, स्मोकिङले पनि गर्छ हैन. स्मोकरलाई नहुने भन्ने छ र खासमा हैन, हो कि